Narayan Sastry graduated from the University of Kansas in 1986 with a baccalaureate degree in geography, completed a master's in regional science in 1988 at the University of Pennsylvania, and then spent 7 years at Princeton to finish a PhD in public affairs and demography in 1995. This article, based on his dissertation research, was published the year after he completed his degree. It was his first publication. After Princeton, Sastry took a position in the School of Public Health at UCLA. During the following decade in Los Angeles, he also was affiliated with the RAND Corporation and the California Center for Population Research. Today, Professor Sastry works at the University of Michigan, where he helps to run several long-term survey research projects, including the panel study of income dynamics, the Los Angeles Neighborhood Survey, and the Displaced New Orleans Residents Survey. This article looks to Brazil in South America for an example of falling death rates, in particular the fall of infant and child mortality. Although some countries experienced this process of mortality decline as much as a century ago, in Brazil this decline in death rates was more recent, and indeed still making dramatic progress in some parts of the country. This meant that Sastry had access to better, more recent information about the conditions surrounding the mortality decline than we have from more remote historical periods, including not only administrative statistics compiled by the Brazilian government, but also information from modern sample surveys of the population that give insights into the personal characteristics and lives of mothers and their babies. Since falling death rates for infants and children play such a central role in demographic change, Sastry decided to explore the conditions that encouraged or hindered these improvements in child survival. The result was a model of demographic research.
Brazil provides us with an example of society experiencing the demographic transition right down almost to the present day. The mortality decline in Brazil did not get started 100 or 200 years ago, but only a few decades ago during the lifetimes of many of the scholars who have written about it. This means that they did not need to consult ancient historical documents, but could draw instead on current data sources. Sastry takes advantage of this availability of contemporary data to look into exactly how that mortality decline took place. As almost always is the case with falling death rates, the progress started among infants and children, where death rates from contagious and parasitic diseases can be prevented more easily than almost any other kind of mortality. Even as late as 1960, after the middle of the 20th century, nearly 130 infants were dying in Brazil out of every 1,000 born, a death rate placing the country at almost the very beginning of mortality decline as part of the demographic transition. But as in many parts of the world, the formation of the United Nations, and in particular the World Health Organization as a specialized UN agency, jump-started the process of mortality decline after the end of World War II. International cooperation led to sharing of knowledge and resources to combat malaria mosquitoes, clean up water supplies, improve crop yields, and in many other ways improve the basic public health infrastructure that would guarantee lower death rates for infants and children. The result in Brazil is clear to see. Already by 1960, the infant death rate was falling, and it continued to decline in a linear fashion right through the end of the 20th century. At the turn of the century, infant mortality in Brazil has stabilized at a rate below 20 per thousand, a reduction of almost 90% from the level seen only a half century earlier. Room for improvement before Brazil's infant mortality rate matches that of places like Sweden or Japan, but remaining progress probably will depend on reducing the harsh social inequality in Brazilian society, a task considerably harder than simply spraying a swamp for mosquitoes or laying some new water pipes through the streets. Sastry is interested in particular in this unevenness of mortality decline. To illustrate the unequal life chances of Brazilian children in different circumstances, he considers two different types of measures drawn from two very different sources of demographic data. First of all, he looks at the conventional factors that most people would think of when trying to explain which children will live and which might die. A health survey taken in Brazil in 1986 asked individual women all over the country about their reproductive histories. These histories included questions about when women started having children, how many children they had, and most importantly for this study, how many of those children ever born were still alive at the time of the survey. From these survey questions, Sastry is able to estimate the risk of death for births to women, his outcome variable that he wants to explain. The same survey also asked women other questions about themselves, including how many years of formal education they had completed and how much money their families made in the year leading up to the survey. These personal characteristics of women often appear in explanations of infant mortality levels and trends. Studies all around the world usually find a strong link between more education for mothers and lower rates of death among their children. This connection could be due to the actual knowledge that the women gained in school, what sometimes is called an exposure effect. If this is the actual pathway for the effect, we could predict that if more of the uneducated women were able to go to school, risks of death would also decline for their births. On the other hand, the connection could mean that formal schooling simply serves as a marker of other kinds of privilege in a girl's life, what is sometimes called a selection effect. This apparent connection between education and lower infant mortality would actually be due to some other advantage shared by the girls who did go to school. If this is the actual pathway for the effect, there is no guarantee that sending more of the uneducated women to school would reduce their risk of infant mortality, because it might not be the schooling itself that matters. To consider this possibility, Sastry includes family income as a separate measure. If his models show an effect of family income on infant survival, but also a separate effect for a woman's education, then we can have more confidence that education itself actually matters. In addition to these personal characteristics of women, Sastry also wants to reflect the fact that conditions in Brazil are very different depending on the part of the country in which you live. Most of the people in Brazil live along the Atlantic coast, with much more scattered populations in the interior western regions of the country. But the southern part of that coastline is much more economically developed and prosperous than the northern coastline up near the delta of the Amazon River. The biggest cities, the richest and most educated people, tend to congregate in the bottom tip of the country, furthest from the equator in the more temperate climate found there. So Sastry looks at characteristics of each subregion within Brazil using federal Brazilian statistics. In particular, since we know that a critical element of public health infrastructure is availability of clean water, he finds statistics on what share of people in each area have access to water, either from wells or from distribution system, and how thoroughly the water has been treated prior to letting people use it. He also considers whether communities have been electrified, that is, whether they are on the grid to have electric power, and the kinds of medical treatment facilities available to people. Within each region that he considers, he also divides the population between urban and rural places, because all of these public services usually are much more widespread in cities than out in the countryside. Keeping in mind all of these possible influences on infant death rates, Sastry then assembles his information to find out how infant mortality changed in each considered community and how such changes were related to each of the possible explanations that he measured. We turn next to the results that he found. We already know that most of the people in Brazil live along the Atlantic coastline, between the border with Argentina in the south and the Amazon River Delta in the north. It should not surprise us to see that Sastry concentrates on these coastal populations in his analysis. Of all the major regions and states in the country, he limits his presentation to results for two parts. On one hand, he looks at the northeast region, including the Amazon Delta along the semi-tropical section of the coastline. On the other hand, he combines together the southernmost three states and the four states forming the southeast region of the country, including Rio de Janeiro and Sao Paulo, the two urban powerhouses of Brazil. Not only do these two parts of the country contain most of Brazil's population, but they also offer a strong contrast in social and economic conditions. For example, in the northeast region centered on the Amazon Delta, half of the entire population lives below the national poverty line. 1 out of every 6 people is illiterate, unable even to read and write, and this figure, of course, is much higher for women than for men. Nearly 1/3 of the population of this region of Brazil can trace African ancestry, descendants of the slaves and other Africans brought to Brazil in former times to work in plantation agriculture for the most part. Although this region includes so much of the population and territory of the country, only 13%, about 1/8 of Brazil's gross national product, is produced in this region. Clearly, economic development has lagged in the northeast part of Brazil, and this could have an effect on infant survival for all women, regardless of their level of education or family income. By comparison, in the combined South and Southeast regions, only 1 out of every 6 people lives below the national poverty line, instead of half the population as in the Northeast. 4% of the population remained illiterate at the time of Sastry's research, only 1/4 as large a share as the 16% illiterate in the Northeast. Only half as many of the people reported African ancestry, 15% in the South-Southeast compared to 30% in the Northeast. And perhaps most importantly, about 1/2, 49%, of the country's total GNP came from these regions compared to the 1/8 produced in the Northeast. These figures paint a stark contrast between life along the southern and northern ends of Brazil's Atlantic coastal regions, where most of its people live. Several of these statistics would seem to predict much better health conditions for infants born in the southern part of the country. To be precise in measuring the survival outcomes for these infants, Sastry considers 2 kinds of demographic measures. The first of these is infant mortality, defined as deaths to infants during the first year of life. If we start out with all of the births reported to a group of women, say for example, women in the urban centers of Brazil's northeast region, who have finished elementary school but gone no further, and who come from middle-income families, we can find out how many of their reported births survived to reach age 1. We can then compare this survival rate, or the reverse of it, the rate of infant deaths during the first year of life, for this group of women, relative to women in other regions, educational categories, and so on. The other measure that he considers is total child mortality, which tracks all the deaths among births to these same women over more than just the first year of life, all the way up to the 5th birthdays. The child mortality measure, therefore, includes infant mortality within it. The difference between total child mortality and infant mortality would give us the death rate for children between ages 1 and 5 after infancy is behind them. Sastry presents results for both of these measures, showing that they essentially tell the same story either way. And just as we might have expected from the economic and social contrasts just pointed out, he shows us that regional contrasts indeed do exist in Brazil in the risks of death for infants and children. His Table 1 shows us that in urban areas, infant mortality was about 3 times higher in the northeast region than in the south-southeast. Out in the rural countryside, infant mortality was about twice as high, 123 deaths per 1,000 births in the northeast region, compared to the south-southeast, 65 deaths per 1,000 births. These contrasts are essentially the same for total child mortality as for infant mortality, because risks of death after the first year of life are always much lower than the risks of infant death in all human populations, at all times and in all places. Infancy before age 1 is the real high-risk period in life, when death rates are most sensitive and revealing as demographic indicators of the quality of life. Another way to summarize these same data in Table 1 would be to focus on the urban-rural contrast rather than the regional contrast. From this perspective, we could say that in the northeast region, infant deaths were about 20% higher in rural areas, 123 deaths per 1,000 births, compared to the urban areas, 105 deaths per 1,000 births. By comparison, in the south-southeast regions, the rural-urban gap looks much more dramatic. There, infant death rates were 70% higher in rural areas, 65 deaths per 1,000 births, compared to urban areas, 37 deaths per 1,000 births. The rural-urban gap was about 18 deaths per 1,000 in the northeast, compared to 28 deaths per 1,000 in the south-southeast. Even the rural areas of the south-southeast, however, had infant death rates only half as high as anywhere in the northeast region of Brazil. Within this overall pattern of regional disparity that still affects Brazilian society, Sastry then turns his attention to the possible ways that infant survival might be affected by mothers' education, presence of clean water, and other details about different communities throughout the country. We conclude our look at his article with his findings about these questions. To his results based on the survey responses of individual Brazilian women, he finds as expected that these personal characteristics also vary from one region of the country to another. For example, his table 2 shows that while the age and sex breakdown of the population doesn't differ much between Northeast and South-Southeast, half the sample is female throughout the country, and the average age of respondents is always about 26 years old, the Northeast is less educated than the South-Southeast. Mothers reported an average of about 4 years of school in the Northeast, but closer to 6 years of school in the South-Southeast. Even in the South, these mothers were not a highly educated population back in 1986, but education has increased greatly since then throughout the country. By the same token, the average household income reported in the South-Southeast was nearly 3 times higher than the average household income of respondents from the Northeast. This tremendous income gap across Brazilian regions remains strongly in evidence right up to the present. Similarly, nearly 2/3 of all respondents from the South-Southeast had lived in urban places for all of their lives, and only 1/4 reported living in rural areas by the time of the survey. The rest included people who started out in rural areas but had moved to cities by the time of the survey. In contrast, in the Northeast, about half of all respondents still lived in rural areas, and only a little over 1/3 were lifetime residents of cities. The survey captured roughly equal numbers of births in the two areas, but twice as many infant and child deaths in the Northeast region. In terms of the community characteristics taken from national statistics, Sastry again finds the same contrasts by region. Over 90% of people in the South-Southeast have access to clean water, and more than half of the population actually enjoys piped or network water. This is twice as high as the 1/4 of households with piped water and clean well water in the Northeast. On the other hand, both regions reported about the same number of health facilities per 100,000 people due to government efforts to establish such facilities in disadvantaged areas. So the stage seems all set to find that personal features like education and community characteristics like clean piped water must be making a difference in infant and child survival. Sastry does indeed find these strong effects in his statistical models, but he also finds an important result that is known as an interaction effect. To understand what this means, first consider the main effects that he identified. For one thing, his results show a strong effect of mothers' education on better survival of infants and children. This is one main effect. He also finds another expected main effect. The more people who enjoy clean water, especially piped water in a community, the lower the chances of infant and child death. This should not be surprising if you consider the health effects for little children of getting your water for washing and cooking from a community ditch that runs behind your house instead of from a well or a faucet. But what about when we consider both of these effects at once? The simplest, most straightforward result would be to find that these two influences both operate independently of each other so that their effects are what we might call additive. That is, if you add more education, you get an improvement in child survival. If you then add clean piped water, you get an additional improvement in child survival. This independence is not what Sastry found. Instead, he found that the effect of one factor depends on which category of the other factor you consider. This is what we call an interaction effect. Specifically, he found that for less educated mothers, those reporting access to clean community water sources were less likely to report infant and child deaths than women who did not have access to such clean water. But when he considered more educated mothers, he found that while they did have better infant survival than the less educated women, this was true whether or not they had access to clean water. For this more educated group, adding clean water to the picture did not give any significant survival advantage for women's children. Sastry concludes from this finding that Brazilian communities were facing a trade-off decision, whether to build schools and provide more education to the young girls who would become mothers, or to provide piped water and other community sanitation infrastructure. Without clean water, schooling helps infant survival. Without schooling, clean water also helps infant survival. However, with schooling, clean water doesn't matter as much. On the other hand, With clean water, schooling still matters. So his recommendation would probably be to build the schools before laying the water pipes. This interaction effect was important throughout the entire Brazilian sample in both northeast and south-southeast regions of the country. Sastry also found another type of interaction effect, this time between other factors and the regions of the country. In other words, some factors were important only in the northeast, but not the more developed south-southeast, while other factors were more important in that southern region, but not in the more backward northeast region. One example of this was household income. Households with higher income appeared to have better infant survival in the northeast region. But with lower overall infant and child mortality, this factor no longer made a significant difference in the southeast part of the country. The same was true for piped water, considered as a factor by itself. It also mattered more in the northeast and was no longer significant in the more advanced south-southeast region. Availability of health services, however, turned out not to predict lower infant mortality in either region. This might seem surprising or even suspicious at first glance, because as the McKinleys showed us, most people tend to give medical services credit as the leading contributor to health and long life. But the Brazilian situation is not actually surprising when we take into account that the government has been working hard for several decades to spread health services out into even the most disadvantaged communities around the country. They also were working on the same assumption that medical services make the biggest contribution to survival gains. Sastry's article is fresh evidence that this common assumption may not be true after all, because despite the spread of clinics, doctors, and nurses into more and more parts of Brazil, the regional and urban-rural contrasts in infant and child deaths still persist. And the education of mothers and presence of community public health facilities still strongly predict chances of infant survival. Without education, clean water, and prosperity, medical clinics by themselves do not seem able to guarantee lower rates of infant and child death. In fact, Sastry turns up a final finding about medical services that disturbed him enough to complain about it in the article. He found that communities with more specialized health services and equipment, like advanced testing labs and specialized clinics, actually reported higher risks of death for infants and children, rather than lower risks. While Sastry is puzzled by this strange result, he hazards a guess that perhaps these communities overspent on investments in such fancy equipment and clinics, penalizing the delivery of basic health services as a result. This is not the only possible explanation, however. This could also be what researchers call a program placement effect. In other words, the higher risks to infants were the cause of putting the clinics where they are, rather than the clinics themselves acting as causes of higher or lower infant deaths. If local and regional governments invest more money in health facilities in the areas with the worst demographic risks, of course you'll find more clinics in these areas. But the clinics are results, not causes. We always need to be on guard against such program placement effects when doing research of this kind. But in any event, we do not get much, if any, support from Sastry's article for supposing that medical interventions are the most effective way to lower infant and child mortality during the demographic transition.